This is Jacqueline from Lichen Sclerosus Support Network, where our mission is to empower people with lichen sclerosus by providing evidence-based education and support so that we can live in a world where those affected by lichen sclerosus are informed, educated, and get diagnosed early. If you find the information in these videos helpful, please consider donating your time or money so that we can continue LS education and support efforts. Now, today I am so excited because we have a special guest who is going to be speaking to us about the differences with vulvar lichen sclerosus in folks with darker skin types, folks with more richly pigmented skin. Do they experience symptoms differently? Do they respond to medication differently? Does it look differently on folks with more richly pigmented skin versus folks with more lighter skin types? We're going to be chatting about that and more today with Dr. Olushola Akinshemoyin Vaughn. I, again, have had the honor, the privilege of hearing Dr. Akinshemoyin Vaughn present and speak at conferences. She's such an engaging speaker, and her work is so fundamental and important to the world of vulvar lichen sclerosus. Now, for those of you who are not familiar with Dr. Olushola Akinshemoyin Vaughn, she is an Assistant Professor of Dermatology at the Medical College of Wisconsin. She grew up in Milwaukee and attended Harvard University, and then she left and went to Los Angeles and played in bands for 10 years, which, like, sidebar, I just think is so cool. So after playing in bands for 10 years in Los Angeles, she returned back to Wisconsin to attend med school at Madison. And then once she finished med school, she went back to Milwaukee to serve her community as an academic dermatologist. And her interests are in vulvar dermatoses, transgender skin health, and global health. So with that, if you find the information in this video helpful, please give us a like. Please subscribe to our channel so you don't miss any more LS content. All right, so welcome, Dr. Olushola Vaughn. I know I've been so excited. I've been counting down the days for this discussion. It's so important, and there's not a lot of discussions around this topic in this space yet. So here's to hoping for a lot more great conversations about vulvar lichen sclerosus, vulvar dermatoses in general, and the differences between how that presents in folks of darker skin types with more richly pigmented skin. So thank you again for joining us today. It's lovely to have you here with us.
Thank you so much for inviting me. I've been really enjoying seeing what you've been doing, Jacqueline, and the LSSN, so I'm really excited to be a part of it.
Of course, thank you so much. So before we kind of go into the more clinical questions, I want to talk about misdiagnoses. And we know that misdiagnoses in the vulvar lichen sclerosus space are quite common, but I want us to put on our little intersectionality hats and talk about the extra kind of barriers and challenges that folks with darker skin types experience when trying to get a vulvar lichen sclerosus diagnosis. So I'd love if you could kind of comment on the current landscape and what's going on and how frequent, or not, maybe not how frequent, I don't know that we have that precise data, but kind of what's going on in that area.
Yeah, I'm the director of Freidert's Mucosal Skin Specialty Clinic here in Milwaukee, and also a woman of color. So I do lots of vulvas. I see lots of patients for their vulvar conditions. And it was just boggling my mind that I felt like I wasn't seeing that many women of color. And, it's important to me. I mean, they've shown that, people of color tend to go back to their communities and, try to serve other patients of color, and that those patients then have better outcomes. And so it was really starting to kind of bother me, like, why am I not seeing more vulvas of color? And so, I thought that I would look into the literature a little bit and maybe do some studies myself. And so I did start to do one study that's still in the works. I had kind of done it, gotten some preliminary data, and now I'm doing it with slightly different methodology about lichen sclerosus specifically and how it might be misdiagnosed in women of color. Because I think that, like you said, it's misdiagnosed in everybody, but I was thinking, maybe is it that we're missing these women, or is it that people of color truly have lower rates of lichen sclerosus, like lower incidence? So when I started looking at the data, the first thing that I wanted to find out was just, when we look at their ICD-10 codes, is it even correct? Like, are people who are getting the diagnosis of lichen sclerosus, do they even actually have it?
Mhm.
And what I've found preliminarily is that they don't, like that there's more misdiagnosis in women of color. It's rampant throughout, but that
Mhm.
especially specifically Black women is what I looked
Yeah.
at, that they do get a diagnosis of LS that is not accurate.
Mm.
And often it's changed, but sometimes that can kind of linger in the system. And the reason that those women are given that diagnosis is most often because of hypopigmentation and itch. So, those
Mm.
are two pretty non-specific, pretty soft criteria for lichen sclerosus. If you're really trying to make a
Mhm.
clinical diagnosis, those are probably not the first two things that you would look at. You'd really look at things like, atrophy, fissuring, anatomic change, biopsy. And so I do think that there is something at play that is making clinicians see these vulvas of color and give them a diagnosis kind of prematurely or not as, not critically thought out as much.
Yeah, I totally agree. And I think that, one thing that might be playing into that is that historically, if you look at medical textbooks, they're all full of images of what, kind of vulvar lichen sclerosus looks like on people of lighter skin tones. And
Mhm.
even the published papers, not just in the textbooks, but when I've looked at published papers, now a lot of them don't have images of vulvas, but the ones that do, it stood out to me that they are exclusively white vulvas. So,
Mhm.
I started to wonder, well, does this look the same on every skin tone? Because I would think that it wouldn't, right? And then if
Right.
we're only seeing this one type of presentation in med school, and then we have Black and brown folks coming into the office and they don't look like that textbook, then maybe that diagnosis doesn't even cross their mind. Um, and so that's something that, I've become more and more curious about. And Dr. Nina Madnani's atlas of, I have it here
Yes.
next to
I have it
me.
here
It's
too. Look
got
at
my
that.
tags. Like the second I heard that was coming out, I was like waiting. I'm like, pre-order, let's go. Because I was like, I don't know, and I support patients with vulvar lichen sclerosus from like a peer support perspective. And I'll often have Black and brown folks coming to me and saying like, I don't understand, like, is this wrong? I don't look like this, or I think I might have vulvar lichen sclerosus, but like I don't look like the pictures on Google. Do you know what it looks like in Black and brown folks? And I say, well, then I'll pull out, Dr. Madnani's textbook and say, I can give you a bit of an idea because we're starting to get more photos now. And that's what we need, right? Is more
That is so great.
photographic evidence on what this actually looks like. So that kind of brings us to the question around what does it look like and what does vulvar lichen sclerosus look like for folks with darker pigmented skin. And I always talk about the distinction between signs and symptoms. For people that have been following me at the Lost Labia Chronicles, I know it seems like I harp on some things and I'm just like a semantic freak, but honestly, the distinction is important and that's why I bring it up. So, for folks that are new here, just really briefly, when we talk about clinical signs, we're talking about things that you can physically observe. So, things like color changes, things like texture changes. We talk about symptoms, we're talking about things that you can physically feel in your body. So, things like itching, burning, like stinging, stuff like that. So, let's start with clinical signs. Is there a difference between how vulvar lichen sclerosus presents between lighter and darker skin types? And if so, what does that look like on darker vulvas?
It's such a complex thing to answer, Declan, because
Mhm.
the answer is yes and no. I
Great.
really want to be careful about drawing divisions where
Mhm.
where that might make someone's life worse.
Mhm.
And I think that, from a pathophysiologic standpoint, lichen sclerosus does the same thing in everybody. Every woman, and I mean that term broadly, like cis women, trans
Mhm.
women, every woman
Yeah.
with a vulva, they, their lichen sclerosus will pathophysiologically behave the same. the
Mhm.
way that it does look different, I think that the pigment is really the main thing, and that's why I also say the same things all the time to people, which is don't be distracted by the pigment. And it's so
Mhm.
hard not to be distracted by pigment, but pigment can be a bystander in any kind of skin problem, in any
Mm.
dermatosis. So you can have post-inflammatory hypo or hyperpigmentation in eczema, in psoriasis, in seborrheic dermatitis,
Mhm.
like everything, vitiligo, everything can have pigment changes. Lichen sclerosus, certainly, but you just need to make sure that you're paying attention to more than that.
Mm.
And then I think the one thing that we also don't understand is the symptom, not the sign, but the symptom of itch. So there's the symptom of itch, which is that a woman feels itchy. And
Yeah.
then there's the sign of chronic scratching, rubbing, lichen simplex chronicus,
Mhm.
and fissuring. And those things may be different in skin of color as well. And we don't truly understand that. But I can say anecdotally, and now this is just my experience,
Yeah.
not any evidence based, that I do think that the women who come to me with problems that are vulva of color problems,
Mhm.
they do manifest this itch and lichenification process. I feel like a little more severely, a little earlier, and a little more
Mm.
commonly. That's my impression. I don't have
Yeah.
data. But so I do think that we have to be mindful of that the disease might be different, might feel differently to people.
Mhm.
But at its baseline, we need to just like to make the diagnosis of lichen sclerosus, you have to have some hard, criteria. We don't have scientific criteria, but there should be some things. You should have, that thinning sensation of the skin, like that the skin is under attack, basically. So
Mhm.
things like atrophy, sometimes that presents as pallor or loss of skin color.
Mhm.
And then that the skin texture is changed. So sometimes that might be that it fissures. That might be that your lips are changing size, that the lips are sticking together, that the clitoral hood doesn't retract as easily. All those things are really hard signs of lichen
Mhm.
sclerosus. And so, if you are a woman of color and you've received a diagnosis of lichen sclerosus and you feel like it's not quite right, listen to that instinct. Get a
Right.
second opinion, really investigate it fully. Don't just, believe whatever you've been told, like really question it.
Yeah. Do you think there's a lot of misdiagnoses between vitiligo and lichen sclerosis, particularly in vulvas of color? Because I remember with your presentation and
Yes.
even looking at Dr. Madnani's presentation, there's such a stark contrast with the loss of pigment, and it almost mimics vitiligo. And so I was wondering if that is maybe something that patients get as a misdiagnosis when there's actually LS going on because they just see that stark contrast and their head goes to vitiligo.
100%. And
Mm.
what makes it even more complicated is that you can have both. You can have LS and
Right.
vitiligo overlap. And so that
Mm-hmm.
becomes so challenging. And really like teasing that apart, I mean, you're really getting into like you need like really excellent vulvologist, experience and, kind of like thinking through like the algorithms and the differentials and how you can tell the difference. That gets to be very nuanced and you really need someone who's very experienced to tell those things apart.
Mm-hmm.
So again, and I always feel sad for people who just really don't have access to a highly trained vulvologist based on geography. And I
Yeah.
wish that vulvar dermatoses kind of lended themselves better to like virtual care. But
Mm-hmm.
I know a lot of people just do not want to send those pictures in now to
Right,
vulvas.
right.
So it's challenging if you don't happen to live near someone who really has expertise.
Yeah, and I would expect that even that kind of telehealth concept of sending, even if you were comfortable, that even then it might still be challenging to have a static image where you can't kind of take a deeper look and move things around. See, like,
Yes.
can I retract the hood of the clitoris? I mean, it could look maybe scarred on an image, but if you were to take a gloved finger and try to retract
Right.
it, it maybe could, right? So telehealth definitely has its place, but I think there are some benefits, especially in complex cases where there are a couple differentials on the table. Like, is it vitiligo? Is it lichen sclerosus? Or is it both? I would think that even though VLS could look like vitiligo with folks of darker skin types, if there's the scarring present, because my understanding is that vitiligo would not have those scarring aspects. It wouldn't have those
Right.
architectural changes. So I think that goes to your point about looking beyond the pigment. and
Right.
seeing, are those their additional changes? And then also listening to the patient's symptoms. Because again, my understanding is that I don't think, correct me if I'm wrong, but I don't believe that vitiligo in the vulvar area would cause intense pain, burning, pain with sex, all of these things that can be symptoms of lichen sclerosus. So again, it does seem that the world of vulvar dermatoses really is like detective work. And
So much
because
detective work.
yeah, there's so much overlap. So it's really listening to the patient, like listening to the patient. I say that again, not for you, but for anyone else listening, because it seems like such an obvious thing, but it's a thing that sometimes does get missed. So really paying attention to the words that they use to describe their symptoms. And then again, looking beyond just pigment, because yes, there can be a loss of pigment with lichen sclerosus, but you're correct in that, like, of course, that's not the only thing that you can see. That's not the only clue that we can look at. So, looking beyond pigment, I think, is a really good and important lesson for any healthcare providers that are listening. And I'm glad that you addressed the symptom thing as well, because I was also wondering if there was, any difference in the way that symptoms are experienced. So it sounds to me like anecdotally, maybe, we don't know yet, but that maybe there's a difference in the way that itch as a symptom is experienced. Is that correct?
Yeah, I think there's so much going on. And speaking of itch, I do want to clarify one thing about
Mm-hmm.
vitiligo. There is an inflammatory form of vitiligo that can be itchy. So in general, we
Okay.
think of vitiligo as not being pruritic or itchy, but it can be.
Right.
Again, that's why then it starts to get so complicated.
Adding.
And
Mm-hmm.
then you can have texture change because they've been scratching at it. And so then it
Oh.
gets to be very, very difficult. You can also have, sometimes when people are aware that the pigment is changing, they're thinking about that area of their body. So they're checking it more, they're messing with that skin
Mm-hmm.
more. And then you can have changes just, that are really, somatically, we'll call that, they're manifested by the brain, which doesn't mean they're not real. They're very real,
Right.
but it's not coming from the skin. It's kind of this complex interplay. And so a lot of, that's what makes the detective work so challenging, is that you have to find all these little subtle things. You have to really know what people have been doing. You have to know what they've been feeling. You have to have a conversation. You have to have time for that conversation.
Mm-hmm.
So as far as symptoms go, yes, I think that maybe in women of color, in skin of color, the symptoms may be
Mm-hmm.
slightly different in terms of itch. Besides that, we should be seeing the same thing. For lichen sclerosus, you should be seeing the same agglutination and,
Mm-hmm.
resorption of especially the labia minora.
Yeah.
One thing I think is interesting and that we may discover more about in the future is how cultural practices relate to this. So
Mm.
things like, certain um, racial and ethnic groups may douche more.
Yep.
They may use different products. They may have different hair removal practices. They may have
Mm-hmm.
different sexual practices. We may have different proclivity to bacterial vaginosis and a different
Yep.
microbiome of the vagina. So some of those things, science is just beginning to understand or not
Yeah.
really even looking at, like what are the cultural practices around hair removal and how
Mm-hmm.
does that, relate to lichen sclerosus? No one's really investigating that I know of. But those things might also, make a difference.
I would think that they would. Yeah, absolutely. I mean, there's definitely, I know that certain shampoos, certain products alone can irritate some people's lichen sclerosus. So then that would be a really interesting study to see the different types of cultural practices and how that impacts, overall disease progression, disease in general, all of that. And so I hope to personally see just a ton more research on all of these, questions,
I
because
know.
they're really, really, really important questions. And
And I would love to find out culturally if there's a difference in how long it takes people to come to the doctor for their vulvar problem.
yes,
Like
yes,
I don't know if there's going to be a racial or ethnic like bend to that, or if it's just like, a history of certain kinds of trauma perhaps that make you a little bit more hesitant about the medical system overall,
mm-hmm.
and especially about, genital issues. You know, I think that sometimes the misdiagnosis is a delayed diagnosis, and that's not only on the provider, but also sometimes on the patient who maybe
Mm-hmm.
for very good reasons didn't come as early, didn't come right when things were starting. And so, I wonder I wish that we had really good information about what makes people stay away so that we could start to work on getting those people in sooner.
Yeah, and I mean, we know that getting patients in as soon as possible is really important, because the earlier we can get the proper diagnosis, the sooner you can get on proper treatment. And the treatment for lichen sclerosus, while it's not a cure, can really help slow the progression of the disease, help manage symptoms, which consequently will improve quality of life. So if we can get to people earlier, then we can avoid some of the issues that come up downstream when it goes untreated. And that's a really interesting question. As you were talking, when I speak to people in, like, I'm always talking about like other people like me with lichen sclerosus. When I speak to other people in, say, China and different Arabic countries, they tell me like, oh, I just didn't go for like 20 years because you're not allowed to talk about genitals in my culture, even if it's pertaining to a medical thing. So it's like, it's one thing to be like, oh, we don't talk about our genitals in the open just while we're out at dinner talking about, penises, vulvas, vaginas. But like, even in a medical context, it's so stigmatized that it's like, you're not supposed to do that. I can't tell my parents about it. I can't tell my doctor about it. Or if, they might say, I only have a male doctor, and it's inappropriate for me, as somebody with a vulva, to speak to somebody with a penis about a vulvar issue, even though it's a healthcare provider. So again, I think there is so much nuance to this, but it would be really interesting to see what is causing people not to go to the doctors. Is it cultural? Is it previous medical trauma, which also can contribute to people not going to the doctor? There's so much nuance and interesting questions that I think come out of this for sure. And again, something I hope to see more studies in the future, because then we can kind of tailor, a lot of our interventions and early interventions to help get people into the right doctors and get them the support that they need. So speaking of treatment.
Wait, hold on. Can I ask you a follow-up question about that?
Of course you can, yes.
I'm wondering, it's just so fascinating that you have had, I mean, such a unique experience in being able to talk to women from around the world about their lichen sclerosus. I wonder, what patterns have you seen? And I'm especially curious about women who maybe have come to the US from other countries, if they kind of bring some of those like taboos and those hesitancies here, or if our medical system, are they able to kind of, approach it differently?
Yeah, that's interesting. Yeah. So mostly when I mean, of course, the crux of the people that I speak to are in North America or Europe, but I do speak to some people in Asia and Africa and South America as well. The people that are typically going to travel to the United States are going to be people from Europe. And I think that just kind of might speak to accessibility with respect to finances, because that's a big commitment to get on a plane, to then have to pay that provider, to pay for a hotel, because no matter what, even if you're not going for a surgery, you're at least going to spend a night in a hotel. So there's a lot of finance that's involved in relocating across the globe to get care. And then the fear still is, I still might not get my answer. And then what do I do for my follow-ups? Like, it might be sustainable to do one initial trip, but then is it sustainable for me to fly every year, to the States to get a prescription renewal, to get evaluated, to see if anything's progressed, to see if we need to adjust the treatment plan. So the few people that will actually fly have been from Europe. The folks that are in Asia, Africa, and South America typically will stay in their countries. I definitely notice in Asian countries, I think, is where I see the highest amount of shame and stigma with respect to, we are just not supposed to talk about this at all, which is why they'll come to talk to me individually. They won't even, because Lichen Sclerosus Support Network, we do host free biweekly virtual support meetings. They're open internationally, so anybody can join. But when there's somebody from an Asian country, they typically come and see me alone, because again, they're like, I can't join a support group because I can't talk about my genitals in front of other people. I definitely can't talk about how this is impacting my sex life. That's an extra layer of kind of taboo and cultural differences that, they kind of struggle with. I would say that, Africa in particular, they really struggle with just access to care, period. So I was speaking with a patient in Kenya a few weeks ago, and they were just having the biggest difficulty finding a provider. And she was telling me, I know I have vulvar lichen sclerosus. I've seen pictures of how it looks in darker skin types, and I've got the signs, I've got the symptoms, and I keep going to these doctors and they don't know what to do with me. The one specialist in Kenya I can't afford. So there's like a twofold issue of affordability and then access. And I think you were saying that, like, access is a big word, right? There's a lot built into that. And part of that is financial, but part of that is also your ability to relocate. If you have a family and you get around by bicycle, you might not be able to travel across Africa, leave your family to see a provider. And so I think that in the African countries, the biggest challenge is just access to a doctor that knows vulvar dermatoses. But often, and she had some pretty sad stories to share with me with respect to doctors kind of actually treating her like she was gross for even coming in to complain in the first place. Like, and that really broke my heart, because it broke my heart in so many ways. Because first of all, no one should ever have to feel shamed by a medical provider for coming in to talk about their genitals. That's just another part of the body. You wouldn't shame her if she said, my throat's sore, or, I hurt my arm, I fell off my bike, I think I got an infection. Like, no one bats an eye. So you should never feel shamed for seeing a healthcare provider. But then I was just like, she had saved up so much money and rearranged so much of her life to kind of get to that doctor, to not only get any answers, no support, but to also leave and feeling like she was gross and wrong, and how dare she even bring that up. So I think access is a really big issue in some of these other continents, and I'm still trying to think of what can we do about that? Because again, like you said, there are virtual care options, telehealth options, but again, those come with limitations, right? So it is possible maybe I know there are some providers in the United States that do virtual consults, and they'll do those from anywhere in the world. But often at the end of the day, the healthcare provider needs to see the patient. They really need to see the skin, and they may need to do some biopsies. They might need to do some minor surgical procedures. And so I'm still just trying to think of, what can we do? And then how can we support patients in the interim? Because we're not just going to magically sprout up specialists all over Africa and Asia in this, like, even if we want to, right? They're not just going to overnight, now we've got thousands per country. It's not going to happen. So I think the question then becomes, how do we support patients in the meantime the best we can with the resources that we have? But yeah, I definitely think there's a lot of cultural differences and a lot of shame that impacts patients and their decision to seek help, but also shame and taboo built in on the provider side too, where they're kind of like, no, I do dermatology. Why are you talking about your genitals? And it's like, well, the genitals have skin, no? Like, that's what this is. But for some reason, all the other skin is okay. Just don't talk to me about that. So I think the cultural influences also can seep into healthcare and healthcare providers. So that adds just, again, another layer of nuance to the story.
Like, we all need to just be talking about vulvas so much more. As providers, we need to be looking at a full body skin exam, looking at the skin of the vulva, and be able to talk about these things with some comfort with our patients. And then I think too, I love what you're doing, because I think that patients need to be spreading the word too, of why, if I broke my arm and it was in a sling, I would tell everybody about it. Oh, I fell out of a tree and this is what happened. And we would just have a big conversation, and we would talk about it at the dinner table, it would be fine. And so obviously there's good reasons that the genitals are not as easy to talk about, but it should not be so extreme. It shouldn't be that we can't talk about it at all. We should be able to talk about, this is something I'm going through. Many women face vulvar diseases. There's doctors who specialize in this, so that people know, because I really don't think that the level, although it is getting better, I don't think that the level of education and awareness is where we really need it to be.
I agree. Listen, I only used the word vulva at 31 years old after I got diagnosed with vulvar lichen sclerosus and needed to Google what that meant. And I actually remember when I was kind of on the tail end of completing my PhD, sitting in a pub with a bunch of my colleagues. And I had said to someone, I was just talking out loud, and I said, oh yeah, you pee out of your vagina. And one of my friends, like I think she probably gave herself whiplash. She was like, I'm sorry, what? And I was like, yeah, you pee out of your vagina. And she was like, no, you don't. No, you don't. You pee out of your urethra. And then she proceeded to take one of these, not tablecloths, but like napkins that they gave on the table. And she took a pen out and she impromptu drew me a vulva, said, this is the urethral opening. This is where the pee comes out. This is the vaginal opening. The pee does not come out of there. And it was just like mind blowing that I had a lot of education for all intents and purposes.
Funny.
Yet here I was saying you pee out of your vagina, and I believed it. I wasn't just saying that in like a funny way. Like I thought, yeah, you pee out of your vagina, don't you? And then so that was one of those moments.
There are so many studies that I want to do, and I think one would just be to give women, like vulva owners, a diagram and be like, can you identify just like the main structures here? Because I don't think I remember the same. I learned that when I was younger. My dad was like he was a chiropractor, so I looked at all his medical books, and I remember the same thing. Like there's 3 holes down there, a pee hole, a sex hole, and then a poop hole. That blew my mind, And I honestly think you're right. Adult women also do not know this. Isn't that wild? It's our own bodies.
It is. It's so wild. And again, I think that also can potentially contribute to delayed diagnoses. Like I've often wondered, it took me 10 years to get diagnosed. I started having symptoms in my 20s. And I often wonder in hindsight, is this because when I would see a healthcare provider, I would say, my vagina hurts. So that they might see the vulva kind of peripheral, but they would just kind of go in, check the vagina and be like, you're good, hon. You're out your door. Like, you're just stressed, calm down, And I wonder if maybe I used the term vulva, that may have clued them in and maybe change things. I wonder. I mean, there's no way for me to know. I can't kind of reverse time, but I wonder if that contributed. I don't think it's the sole factor, but I think it could have played a role. And I agree with you. Like, I just want to normalize vulvas, genitals in general, because to your broken arm thing, I always think like, I wish that we could talk about vulvas the way we do about like strep throat. Like, if you think about it, you ever shine a flashlight and look at yourself when you have strep throat? It's not pretty, right?
Right.
Like there's like white papules and hyperpigmentation, like red streaks. There might be some pus. Like it's not, but if I talk about my strep throat, that's okay. And that's normal, and no one bats an eyelash. But if I say, oh, my vulvar lichen sclerosus is flaring today, it's feeling really itchy, and my vulvar skin feels really raw and irritated, oh dear Lord.
It's like, oh.
Now I get the looks. Now I get the who raised you? How could you talk about this in public? And I'm like, well, it's just a body part.
Yeah, like, you should be able to talk about these things. And I think for your listeners too, I'm sure there are many parents in your listenership who maybe are parents of young vulva owners. And I think, I remember hearing the story about a girl who was going to school and telling her teacher that somebody in her house was touching her diamonds. And the teacher was like, okay, great. Like, we need to move on. Let's go to the math lesson. Like, didn't pay any attention to it. She kept saying it and saying it. Well, she was being sexually abused, but she didn't have the language to call her anatomy what it was. And I think it's so important for us as parents to say, like, this is a vulva. Call it, one of my proudest moments as a parent, I have a daughter, and I heard her correcting my partner, my husband. She said, that's not my vagina, Dad. That's my vulva. And I was like, yes,
my God.
I was so proud. She's 7. And I was like, yes, the girls need to be able to say for exactly the reason you said. Like, if you had gone to the doctor, what could have been different? How many women are having that experience right now as we speak? So like giving kids the language to describe their anatomy is so important.
So critical. Wow. I got like vicariously proud for you.
Thank you.
I don't have any kids, but like, and my niece is like not really of that level yet, like too young to kind of speak to that extent, but like, oh, I'm going to teach her. I'm going to teach her. There's no way she's walking around calling it her vagina. No, she's going to know the differences. But yeah, we really
And
do
this
need
is
to
another, like,
normalize this.
communities of color issue. I do think that certain communities, they have I think that,
Oh,
it's
yeah.
easier maybe for people who are, like, socioeconomic status, like, more educated to, like, use
Mhm.
anatomic terms when they're having, like, the bees and birds talk with their
Yes.
kids.
Yeah,
And I do think that some of that then kind of trickles down to, like, race and ethnicity just by virtue of, like,
absolutely.
economics. And so I
Mhm.
think that some of our communities of color don't teach their kids as much and don't use those words
Right.
themselves as much. And so that's
Mhm.
it does become a little bit of like a racial issue.
Yeah, it absolutely does. It's interesting, like, how many nuances and issues we've already identified. So just showing, like, hey, anyone, everyone, this needs more research. Like,
Yeah.
this really,
And the
really
last
does.
one, if I may bring up one last thing that I think
Yeah,
is
please
also kind of
do.
like a topic in skin of color around this, is that providers, I think, sometimes forget, or maybe we're just not think we have so much to think about. We're not thinking about it as much. Just how important skin color is in identity to people of color.
Mm.
Like if you're a person of color, you call yourself, I'm a person of color. It's like
Right,
part of
right,
your
right.
identity. Whereas, if you're a white person, you might not be like,
Yeah,
so, when you start to lose pigment, you might not be like, oh, now I'm not the same white that I was before. Like it maybe
right,
doesn't
right, right,
impact you
right.
as much. You know what I
Yeah,
mean?
yeah, yeah.
And I think that when, for I've seen some people so devastated by their vitiligo, by their LS, by
Oh,
hypopigmentation in the
yeah.
vulva. It is devastating to them that they've lost the color. They don't care about the itching. They don't care about the anatomy. They don't care about, they're
Mhm.
just, when will the color come back? Is the
Right.
color change permanent? Is this scar? Like, what can I do about the color? Because
Mhm.
we're so bound up in that identity, and so I think if we are taking care of patients who are, that is their identity, that we really have to honor and respect that, and not think that it's like cosmetic or not as important,
Right,
but really
right.
that it is really important to certain
Yeah.
people.
I love that you said it's not just cosmetic, because I think
Mm,
that, I mean, a lot of skin conditions in general get kind of chalked up to a cosmetic concern, an aesthetic concern, but I can especially appreciate, and it's true, because my vulva, which was pink prior to, VLS kind of progressing, but when I was diagnosed, it was essentially all white. But the contrast wasn't as obvious because I was already so pale. That extra paleness, it didn't really seem like a huge contrast. It was much more subtle. And like you said, it's not really bound up for me in an identity type way. So there's not that extra layer that's adding to or going to impact my quality of life as much. And I'm curious to know, in your experience, when we talk about the color, when will the color return? Will the color return? What does that look like, especially in more richly pigmented skin? So I know in the literature I've seen that it can take anywhere up to a year to get the color to return, and that there are some cases where people don't get that color returning. So what does that kind of look like for you? What do you see in terms of timeline and color returning?
I think I'm very upfront initially with patients who
Mm-hmm.
have like a hypopigmenting vulvar disease,
Yeah.
to let them know that the pigment might not return. And we
Okay.
have
Yeah.
conversations about that every time that we talk, because it's like I want them to not feel sad about the color if possible. Like, I want them to
Mm-hmm.
understand that they can still have sex, they can still have babies, they can still,
Yeah.
go to the beach and look beautiful, and they can do all
Mm-hmm.
the things. And so that, we're going to try to focus on the health of the vulva, the risk of
Right.
squamous cell cancer in
Yeah.
lichen sclerosus. We're going to do the things that medically are the most important from a like kind of longevity and,
Mm-hmm.
cancer standpoint. And
Yeah.
then we're going to address the color as well as we can, but that
Right.
that might not ever be back to the vulva color you had when you were 16.
Mm-hmm.
And I do think that color can come back in vitiligo, certainly, because we know that those melanocytes are still
Right.
living in the hair follicles, and so they'll
Right.
repigment from the follicles. In lichen sclerosus, we don't understand what is happening to those melanocytes. We truly don't really understand why those melanocytes go away. Like,
Mm-hmm.
the autoimmune disease is attacking keratinocytes. So like, what's going on with those melanocytes? Are they just burned up in the fire?
Yeah.
Then how do we get them to come back? So we don't really know. And what I've seen is that that the color does slowly start to come back, usually kind of like from the edges, sometimes kind of
Hmm.
diffusely once we get the skin calmed down. But I have several patients, and this is, I've not been in practice decades, but so, this is for a few years that I can say
Hmm.
that, that they've been healthy for a few years, and yet the color has not come back. So
Right.
that is certainly an outcome too, and I think that people need to be prepared for that outcome.
I love that you're so upfront with your patients about that, because I'm very big on setting people's expectations in a realistic way. Because if you tell your patient, yep, no problem, your skin color will completely return, it'll happen in a few months, now they've got that hope. And then when
Mhm.
it doesn't happen, or if it doesn't happen maybe fully, because there's sometimes maybe a partial return of color, but not, like you said, not the vulvar color that you had when you were 16 per se, that can be devastating, especially in the context of having these, identity pieces tied to the skin color. That can be extra devastating. So I do think it's important that healthcare providers are honest and manage expectations. And I too have been curious, why do some people get the return of color and what, what I mean? Because
Right.
it does seem like during that inflammatory response, like the melanocytes and tons of other cells get kind of attacked in the process. So, okay, we've got diminished melanocytes that accounts for the reduction in pigmentation. But why do some people get the return? Why do some people have a partial return? And what's going on with the group that never returns the color?
Hmm.
Like, I'm so
Right.
curious to know why that happens. But like you mentioned, we don't really fully understand that yet. So again, because we don't know, the best we can do is say, no guarantees, no promises. And let's focus on the health first. Let's always focus on making sure this doesn't progress to vulvar cancer, anything like that, obviously. But yeah,
Yeah.
love,
And I
love,
think
love
that
that
we
you do
are
that.
learning, there is good data because people are studying vitiligo kind
Hmm.
of so robustly. We do have data
Right.
about like the T resident memory cells, and
Hmm.
they're even, I think they're starting to even have some therapeutics around the resident memory cells.
Right.
So I think that because, like, thanks to that, I think that we
Hmm.
might have some hope on the horizon for LS too. So
Fingers
we'll see
crossed. Yeah.
we'll see.
Yeah.
Fingers
Because
crossed.
you're right. I know there are some people that are very devastated about the loss of color. And so I think to have more targeted treatments or options available to help bring that color back would be great news for many patients across the board.
Yeah.
Let's pivot over to treatment a little bit. Do you think, or is there any research looking at, is treatment when we look at like how effective it is, how it's absorbed in the body, are there any differences in efficacy and absorption amongst different skin types, or is that something that's not been quite investigated yet?
There is some data. Again, this is one of those places where I'm like, I don't want to build up, I don't want to
Yeah.
divide people when, what we need in the world right now is to like bring people together.
Yeah.
But I think that there is some data that medications kind of cross the skin barriers
Hmm.
differently in different skin colors. Um, that there's like data that goes back to the 90s kind of saying this. And
Okay.
then I think looking at that kind of fell out of favor a little bit. And now
Mm.
in recent times, people have kind of started looking at it again, just in terms of what proteins are expressed and like in
Right.
what ratio those proteins are expressed. And so I don't know that there's much of an appetite to really separate this on
Hmm.
racial lines. So we might never really have an answer for that.
Right.
But I do think that it is important to consider that the medications may work differently in different skin colors.
Right.
And what that looks like is that some of the steroids might not kind of get to the problem areas in lichen sclerosus when it's more richly pigmented. So
Mm.
our topical steroids might not work as well. All of the data that we have for clobetasol in LS, so like gold standard, at least here in the
Yeah.
US,
Hmm.
mometazone maybe in Australia, but clobetasol, gold standard. I actually looked at all of the studies that we have
Hmm.
showing, that said that established clobetasol as the gold standard. to see were women of color included in those studies, and most of
Mhm.
them don't really report their
Yeah,
racial
it's
demographics.
frustrating.
But like you noted when you were going through, textbooks and papers and looking at the images,
Mhm.
there's actually I sincerely believe that the number of women of color that were included in those establishing studies could be zero.
Mhm.
It could be.
Yeah.
And so, it does raise the question of, do we know that it is going to work for everybody? I do
Mhm.
think that the patients that I have, women of color with LS, and it's a very small population, but I do think that they have responded well to topical steroids. So that does give me some reassurance.
Yeah, that's definitely great to hear. I've definitely become a little bit more interested in personalized medicine. So
Mm,
curious, because I mean, clobetasol does have huge, robust safety and efficacy research behind it. But still, nonetheless, there are full responders, partial responders, non-responders. And there are people that do well on a maintenance of 1 time a week versus 3 times a week. And so I'm always kind of, curious about those nuances, those individual nuances and how people are responding and what's going on. Why are some people non-responders? Why are people partial responders? And how can we better tailor the treatment plans that we have so that individuals can benefit from the medication? Um, so I did ask you this question during the vulvovaginal health update, but I know you answered it, but I don't want the answer to stay in my head. I want other providers to hear the answers. I want other patients to hear the answers. And this is kind of going on topical clobetasol. So to give context for the question for people that are kind of more new here, I asked a question about signs of too much steroid. And the question came from a podcast interview between Dr. Selk here in Toronto and Dr. Gail Fisher in Australia. And the question was kind of around like, when do we know when to increase clobetasol? When do we know when to decrease clobetasol? And Gail Fisher had a really simple answer that was kind of easy to remember, which is if the skin is white, step it up. If the skin is red, step it down. So initially I was like, okay, I like the simplicity and that that's easy from a patient perspective. Like those are layman's terms. It seems easy. But then I was like, wait a minute. Red isn't going to look red on everybody's skin though. And so
hmm
how would, a patient with darker skin color, how are they going to know? Is it going to be harder to see? Maybe it won't even look red. Maybe it's more purple. Maybe it's more blue, right? So then, my question was, if you've got a patient of color, what kind of sign would they be looking for with respect to too much steroid? Because I will say that that's a big concern in patient communities. A lot of people are worried, am I using too much? Am I having a dermatitis type reaction? You know, but
hmm
telling you just look for red skin is not always going to be helpful depending on the color of your skin.
Right, and also look for white is not helpful because sometimes you can have like LS in full remission and a person of color might still just have white. It might just be
Yeah,
persistent
yeah,
hypopigmentation.
yeah.
So yeah, hard to say there. I think the question of erythema in skin of color,
Hmm.
you've probably heard me, on my bandwagon about this,
Yeah.
that, we will say like it's harder to see in skin of color, but the real truth is that we have not been trained to detect it in skin of color,
True.
because we just haven't seen the images in textbooks and in
Hmm.
papers and in practice. And so I do think that of course, there's some like optics at play. There's,
Sure.
reflectance, and there's, like background and like our ability, like
Hmm.
our cones and rods, just ability to discern two things.
Yeah.
But I just think that we just need to practice more. And
Great.
there's certainly steroid phobia in many communities and in many parts of the body. I
Hmm.
love the vulva so much because for so many reasons. But one of them is that I think the vulva is truly rather steroid adverse effect resistant.
Yeah.
I think the places that I've seen very bad steroid side effects are actually the genitocrural folds, like between the labia
Hmm.
majora and the thigh, and then onto
Yes,
the
I
thigh,
agree.
and then sometimes like Mons lower abdomen.
Hmm.
It's like the vulva, like the parts of the vulva themselves pretty tough. Like when you think of
Yeah.
all the things that they're made to withstand, periods and sex and childbirth and all of the
And
pee, I
poop,
mean, all
poop,
this stuff,
poop
and
gets
poop
there
too is
too,
in there.
like
I mean, it's like the vulva is awesome. It's pretty tough.
Mhm.
You of course don't want to be reckless with your steroids. And I
Correct.
have definitely had a lot of people have steroid erythema.
Mhm.
And then we kind of have to like get them off. I tell them it's like they're now kind of like an alcoholic. They need to
Right.
basically like detox, and it's going to be rough.
Mm.
So those signs are very subtle, and I do think and you need some level of expertise to know, because other things can be read. If you've been using steroids for a long time, maybe you have vulvovaginal candidiasis, and maybe that's at play. Maybe you're
Mhm.
putting something else down there that you didn't tell us about, like emu oil or something else that then you have a
Right.
contact dermatitis too, and that can be read. There's a lot of
Mhm.
reasons for red besides that you've overused your steroids.
Right. So again, maybe I think from a patient perspective, I think the takeaway here is to go in and get a clinical exam if it's accessible to you, because simply seeing a color, it, it could mean so many things. It really can. And the only way to really get clarity on that would be to get a clinical exam by a provider who's very knowledgeable about vulvar dermatoses, because that's really going to make a big difference. Because if you've got candidiasis and you're just slapping more and more and more steroid on, it's like, well, that could
Right.
actually end up making things worse. But a lot of people will think like, oh, I'm itchy, so it's got to be my LS flaring, so they put more steroid. I'm getting more itchy, so they put more steroid, more steroid, more steroid. They're like, oh, I'm red, it's my LS, more steroid. And it's just like, again, and this is why I love and don't love telehealth, because that could get missed over a telehealth appointment if you're not there to really, really get a fine-grained look at what's going on. So yeah, thank you for sharing that, because I know that's a question that comes up a lot in the kind of support group spaces. And I've been really trying to watch how I use my language and how I use color as when answering a question. So, kind of to your point, even saying white step up, more complex, it's more nuanced than that, right? So just really, for me, catching myself being mindful about how I'm talking about color changes, because they're not always helpful. So thank you for answering that. So to kind of pivot a little bit away from the clinical stuff, I want to know, and this is just like opinion, do you have any advice for patient leaders, patient advocates for supporting and advocating for people of color with vulvar lichen sclerosus?
Hmm. Um, Gosh, that's tough.
I
You're
know
doing
it's
such great work already. I feel like you are being an excellent leader in this space. Um, we kind of talked about, you know, honoring the importance of color.
Mhm.
We talked about cultural sensitivity and kind of, not, we didn't call it that, but I think that's kind of what the discussion
Sure.
was, just around
Mhm.
cultural practices and the words that you use, the language. Um, and then I think that maybe one other thing would be to make sure that patients are aware of the HPV vaccine. Now,
Mm.
there, in LS, so LS leads to squamous cell cancer, so does HPV. These are like two
Yes.
pathways that you can go to get to squamous cell cancer. Um, Sometimes people can have both things at once. They may have lichen sclerosus and a
Mhm.
history of abnormal pap smears
Yeah.
and HPV infection. And I think that the uptake of the HPV or Gardasil vaccine could be better. It's kind of like one of these like World Health Organization priorities to like eradicate cervical
Mhm.
cancer. We need more people to get their HPV vaccines worldwide. Um, I don't know that the education around HPV vaccines in the US is, again, like where we need it to be quite yet.
Yeah.
Knowing that the best time for the HPV vaccine is before you're sexually active. Knowing that you can get the HPV vaccine still up to age 45, even though
Mhm.
the first age that you can get it is age 9.
Right.
Knowing that it's a 3-dose series and that you want to complete the entire thing, but that one vaccination is better than 0. I think that if we could help with some of the HPV, like reducing HPV signs then and HPV
Mhm.
cancers, then I think that we will kind of by default take better care of our LS patients, because
Right.
sometimes there's overlap and that
Yeah.
becomes really difficult, and people might be getting over biopsied and over treated, and they
Mhm.
muddy the water. They each muddies the waters of the other.
Yeah. No, I love that you said that, because for the longest time I thought I couldn't get the HPV vaccine because I found out about it when I was already sexually active and was in my 20s, and I thought, oh, I can't get it. And then I was at, I don't even know, some university clinic that you go to in between classes. I don't even know what I was going for, but they were like, oh, do you want to get your HPV vaccine? And I was like, oh, no, I can't. I've already been sexually active and I'm too old. And they looked at me like, that's okay. And I was
It's
like, what do you
okay.
mean that's okay? And they're like, oh, we could do it right now. And then they, explained kind of what you just explained. And then I was like, okay, let's do it.
Yeah, let's do it.
So, I
Yay,
mean,
good for
yeah,
you.
I got all three later in life, but I'm glad to know that now. And I didn't realize that you could get as young as 9. That's
Mhm.
that's great. Okay.
Yeah, so I mean, we can make this choice for our kids. Like I said, I'm a parent. I have a
Yeah,
12-year-old boy, and he has already gotten his vaccine because that's the
I
best time. And it's
love
not just girls,
this.
it's not just cervical cancer.
I know.
Boys can
Yes,
also get HPV, especially like head and neck kind of throat cancers.
yes, yes,
And
yes.
those can be fatal. So as
Mhm.
soon as he was old, I was like, "Yep, you're getting this vaccine." Like, yeah, no
Yep.
consent, no autonomy. Like, if I am going to give you something
Get in
that's
the
going to
car.
save you from cancer, I'm absolutely going to make that choice for you. So,
Right.
yeah.
No, yeah, it's super fair. It's true. I didn't know that either. My cousin recently got hers again at a later age, and she went with her husband, and they were, the doctor that was administering the vaccine went like, "Oh, do you want to do him too?" And he was like, I have a penis," and they were like, yeah, that's okay."
Yeah.
Like, because again, I think that Gardasil was really marketed for kind of, people with
Yeah.
people with
Very much for
vaginas, and it
cervical
wasn't
cancer. Yeah.
like, yeah, with the cervical cancer lens, I never really heard about it in a, penis owner kind of lens before. So that, was new to me. So I'm glad that you mentioned this, because this definitely gets me excited and thinking about other ways to bring more awareness to this. And I think that's also really important, because actually I talk to a lot of people with lichen sclerosus that also have HPV.
Hmm.
And I'm seeing this more and more in the support groups. There's always one or two people saying like, "Hey, does anybody else have HPV?" And then you just watch, some hands go up. So I think that, remembering those hands going up and how common that is in conjunction with this conversation definitely inspires me to kind of talk more about this and raise more awareness in 2024, since we're almost done 2023 at this point.
Oh my
Um,
goodness.
definitely will be in 2024 by the time this video goes live. So if we can just maybe rapid fire do a couple quick more things, and then we'll close out. Just, talking about the complexity of vulvar lichen sclerosus. Vulvar lichen sclerosus is a lichenoid condition, and there are other lichenoid conditions like lichen planus, like lichen simplex chronicus, and we've kind of alluded to those before. But I'm wondering if really quickly you could comment on, kind of the same questions. Are there anything that healthcare providers or patients need to know about how lichen planus and lichen simplex chronicus might present in folks of darker skin tones? Anything that, might be helpful there?
Um, for lichen planus, I really want to start studying lichen planus more in 2024,
Mhm.
because I think that there probably is some racial, like, I think maybe there might be a racial difference in incidence, and
Okay.
it's such an understudied disease, and I'm kind of
Mhm.
excited to maybe give it a little more of my attention
Yeah.
in 2024. The most common type is erosive lichen planus.
Yes.
That's kind of like when we talk about erosive, or when we talk about lichen planus with the vulva. A lot of times we're talking
Yeah.
about erosive. And one big difference between that and vulvar LS is that erosive lichen planus doesn't tend to go around the anal skin. Whereas we
Mm.
all know that figure of 8 for lichen
Right.
sclerosus, like it will definitely involve the anal skin frequently. So that's like
Mhm.
one kind of easy way to tell the difference. Um, the other thing is that for, more cutaneous or papulosquamous lichen planus, you can look for the signs elsewhere, and people of color especially will kind of like often have this like long-standing hyperpigmentation where some of the cutaneous, the body LP,
Mhm.
might have burned itself out over time because it can do that.
Mhm.
Whereas erosive LP tends to not burn itself out. It needs to be treated.
Right.
So those like looking for signs elsewhere, especially hyperpigmentation in skin of color, and then looking for the anal involvement across all races, I think are good, just like basics for LP versus LS. And then for LS versus LSC, LSC, lichen simplex chronicus, is kind of like a diffuse itching and thickening of the skin.
Mhm.
You can, lichen simplex chronicus is an umbrella term. It can be caused by so many things, and LS is one of those. So you can certainly have both things.
Mhm.
But in general, the kind of the hallmark then of LSC is that like thickening, the lichenification of the skin. Whereas with LS, the hallmark is really the thinning of the skin, the atrophy because of
Mhm.
the attack on the dermis. So I'd say that's probably the biggest thing to tell those apart. And in skin of color, then the difference especially is just like the dyspigmentation that you get
Mm.
from the chronic scratching, the lichen simplex chronicus.
Right. Okay, perfect. Well, thank you so much for that. Is there anything that you wanted to say on this topic that we didn't get a chance to say that you would like to kind of say now?
We covered so many things, Jacqueline. This
I
has been
know
so
we
much fun.
did.
I guess the last thing I will say is that I would love to hear stories from women
Mm.
of color with LS or any vulvar disease. And so I think that maybe the website is going to be in the show notes.
Mhm.
But I do have this website that I'm kind of like entertaining the idea of a kind of a vulvar side thing. It's called avlove.me, and there's an email on there, info@avlove.me. And if you want, I can't give medical advice. I can't respond to most of the emails.
Mhm.
But if you would like to share your story with me, I would love to hear it. I just would love to hear the experience of women of color who are wrestling with vulvar disease. I can't get enough of that. So yeah, please reach out.
Yeah, that'd be great. I would love like a storytelling, like a zine or a compilation or
Mm.
something kind of highlighting the different, and cultural differences as well. I think that would be a really nice thing to have. So, of course, usually at the end I ask, if folks want to reach out to you, how can they reach out to you?
Yeah.
But I think that kind of
I
answered it,
stole it. I
right?
stole your
So
thunder.
I think no, that's okay. So I think the info@avlove.me would be the best place to kind of reach out if anyone wants to. And then if you're accepting patients, where are you located for folks that are in that area that might want to see you as a doctor?
Yep, excuse me, I'm in Milwaukee, Wisconsin. I can take care of patients from anywhere across Wisconsin, but I only have a Wisconsin medical license. Some patients in Northern Illinois and like Western Michigan can also kind of be covered to see us here in Wisconsin. And I am taking patients, although the wait times, the access, like we talked about,
Yeah.
access. So there is a bit of a wait, but please, waiting is better than never. So, if you are in the state, then please call and get on the list. It's Freighter Hospital.
Perfect. Thank you so much. And to any providers, I mean, especially to providers, but even for patients that kind of want to see more images of vulvas of color and the different, vulvar dermatoses that are out there, definitely pick up the Atlas of Vulvovaginal Disease and Darker Skin Types by Dr. Anina Matnani. It is absolutely fantastic. So thank you again, Dr. Shola Vaughn, for this wonderful conversation. It was such a pleasure. And goodbye to all the viewers. We will catch you in our next video. Bye.
Thank you.